we are quickly going to learn about few commonly presented endocrine cases that we come across, especially in adolescents, right? And we have kept it very, very case-based. We are going to discuss the common case scenarios that we encounter in this age group. And I hope with all the panel esteem that is sitting here, we are going to have a good learning experience. So we directly go to our first case. So I have got a 14 years and 9 months old boy who has come with complaints of him being the shortest in the class. Parents say that there is no development of any secondary sexual characters. The child is otherwise healthy, good at school and sports, and is teased at school. So I would like to ask Dr. Arun Kumar sir, if a child like this comes to us, how do we approach him?
Thank you. First of all, I like to thank you, sir. Hello, hello. Come. Thank you, the organizer. First, okay, they give me opportunity to.
Can somebody help with the mic, please?
Hello.
Yeah.
Thank you. Thank you. Okay, I will go. In this case, I will go through history, like growth history, or even growth history. The other is okay. Growth history. Then I will go growth history. Then parental history. Then I will go other like a family history, past history, like any chronic disease like asthma, or even renal related disease, or any other, or examination. I will go through anthropometry, weight, height, length, and also going to plot the growth chart, the WHO, or even Indian Academy of Pediatrics, and SMR staging. We are going to do for that side.
Yes. Yeah. So as sir said, we are going to take a thorough history. No, a family history would be very important, knowing what age the parents started their pubertal development, was there any delay in starting the puberty or not, and very, very important for us to plot them on the growth charts. So this is the weight and the height. Like sir was asking, what is the weight and the height? So the height is 145 centimeters, weight is 30 kg, systemic examination is normal, and when we do the SMR staging, the child has no axillary hair, no pubic hair, and the testicular volume is 4 ml. Now, luckily, we have got a height measurement that was done at the age of 12 years, which is 130 centimeters, right? So, if you just get the growth velocity, it comes to around 5.5 centimeters per year. So, if I just quickly summarize, the child has always been healthy. Like when we were looking at the history, always ask for the history of secondary dentition, because that can be an indirect evidence to what the bone age can look like. And here mother reports that the secondary dentition started at around 9 years of age. There is history of short stature in the father until 12th grade, and father says that uske baad meri height bahut zyada badh gayi. Otherwise there is no history of short stature or any major illness in the family. And this is what the growth chart looks like. So this is the height, which you can see is definitely below the 3rd percentile. But if you can see that, the height taken at the age of 12 years looks like a normal growth velocity. And this is what the weight looks like. So Jankna ma'am, my next question is, having this basic data, what should be our next step in the assessment of this child?
Yes, height is less than 3rd percentile, weight is less than 3rd percentile. With the height, growth velocity between 12 to 14 years is limbs normal. So I would like to have mid-parental height calculations and plotted at 18 years of age.
Correct, right? So it is important to know what the parent's height look like before we start interpreting the child's height. So very, very important to calculate the mid-parental height. For a boy, it's going to be mother's height plus father's height plus 13 divided by 2. For a girl, minus 13 divided by 2. Plot this at 18 years. And then let us see what it looks like, right? So this is what the target height looks like. It is right here. Sorry.
Yes. Yes. So with
right?
this.
Yes. So child apparently is quite short for the target height also, right? You can see that parents are reasonably okay, but the child looks quite short for the target height. So what should be our next step? Yes, Ruchi ma'am.
Okay, so here we have an apparently healthy child coming for short stature at 14 years and 9 months of age. We know that child is so apparently healthy with normal systemic examination. We are probably looking at physiological forms of short stature. Child is short for the family. I would like to look at the bone age to see what the bone age looks like and what is the height potential of the child. What is the predicted adult height of the child
Yes.
if that falls in normal range or within
So
target
bone
height.
age is a very, very simple clinical tool, right? You just get a simple x-ray of the left hand. There are various methods where we can do the bone age estimation, but it helps us to know what is the skeletal maturity and what is the growth potential. So in here, the child is 14 years and 9 months of age. The bone age is only 13 years, right? So when we put the bone age, so usually we use a triangle to plot the bone age. So when we put the bone age here on the growth chart and then extrapolate the height from the bone age, the child seems to fall in the target height. Yes? So, but still, Dr. Chetan, the child is 14 years and 9 months of age. What advice would you do next for this child?
I think though, looking like a normal growing child, just short for the mid-parental height with delayed bone age, but definitely because it's a case of delayed puberty with short stature, we would like to evaluate further in terms of investigations like whether any chronic disease persists, and also I would like to see the HPA axis to be evaluated for to see the cause of delayed puberty.
Correct, right? So though things look like a constitutional delay, but at the same time, the child is already 14 years, 9 months of age. So we should get all our basic investigations done, including our basal sex hormone. So here we're talking about LHFS and testosterone. So here we went for the same investigations for systemic illness is absolutely normal. We found that the bone age is delayed, and these are the levels of LH, FSH and testosterone. Chetan, any comments on what these levels look like?
Yes. So LHFS and testosterone levels are, we can say, pre-pubertal, because any LH more than 0.3 is suggestive of onset of puberty, and LH is the most sensitive marker to see for pubertal onset.
Correct.
So definitely this is a short stature with pre-pubertal child.
Yes. So, so definitely pre-pubertal blood work here. Dr. Ruchi, if you can just quickly summarize the case so far.
Okay.
I mean, sorry, because, you know, I think as pediatricians, history and basic is very important. So we're going to do that.
Yes, so 14 years, 9-month-old child has been growing always, but below the 3rd percentile. Coming at this age with bullying at school, and child is apparently disturbed because of the short stature. Systemic examination and blood work is normal, which is quite important. Bone age, again a single note about the bone age. We typically do a left hand x-ray to look at the bone age. And in the bone age, we look at the epiphyses and their shape and the fusion to see what chronological age the bone age is matching to. So if the child's bone age is 13 years, we would plot the child's current height of 145 at 13 years to see where the bone age is, and it will tell us about the growth potential of the child. There is history in the family, which is quite common sometimes in constitutional delay, that father is clearly giving a history that he was short until 12th standard and then grew. Probably father also had a delay in puberty. Child is clinically entering into puberty by looking at the gonads. The bilateral testicular volume is 4 ml, but still biochemically, since the LH, FSH are pulsatile hormones, the hormones are still not like in pubertal range. We have seen that growth velocity normal. A normal growth velocity practically rules out growth hormone deficiency, thyroid deficiency, the hormones which are basically responsible for majority of growth in the pre-pubertal age. So I would...
so specifically, I want to ask, you know, like, are we dealing with something serious? Any possible clue from the clinical exam which is in favor of a positive prognosis here?
Positive prognosis, yes, because height potential is good, because there is, so typically a boy would grow till a bone age of around 16 and a half, and the bone age is still only 13. So child has good amount of height potential left. That tells us good prognosis. Normal growth velocity tells us about growth prognosis, and a family history, positive family history, which is often found in children with constitutional delay, being a boy, because again CDGP is something which is more common in boys than girls.
Yes, and the most important thing, testicular volume of 4 ml shows that puberty has started, right? So I think that is again a very, very important clinical examination which needs to be done. So just a quick brief on what we look like at constitutional delay of puberty and height, that is what we call as late bloomers. It is probably one of the most common causes of delayed puberty. It happens more in the boys as compared to the girls, right? Most of the times the causes are unknown. Remember, you need to rule out all the other disorders before you say that this child has a constitutional delay. Family history may be positive, and typically the growth charts look like this, right? They look short, and then as puberty hits a little later, they start pulling up on their height and end up in their target range. Sometimes it is difficult to differentiate from the pituitary causes, that is your hypogonadotropic hypogonadism. Remember, the bone age is usually delayed within 2 years, right? LS-FSH testosterone may be pre-pubertal, but the onset of puberty indicates that here we can wait and watch and see what we can do. Sometimes we might even give a short course of testosterone. So in this case, the child was reassured, but remember, monitoring and follow-up is very, very important, right? We always say that if you don't look your age, it's a compliment. Somebody who's 60 or bole, ma'am, aap to 30 ke lag rahe ho, ma'am to bahut khush ho jati hai, right? But in this case, if it's an adolescent, remember, you want to rule out a major endocrinopathy, right? So if you have any red flags, as in no sign of puberty before the age of 13 years in girls or 14 in boys, if there is a poor growth velocity, remember in this case the child had a normal growth velocity, but if the growth velocity is poor, if the bone age delay is more than 2 years, there is any dysmorphism, any midline defects, undescended testis, micropenis, any associated systemic illnesses, like, you know, the child could have nephrotic syndrome, recurrent episodes, there could be long-term use of steroids, any complaints of headache, blurred vision or vomiting, then proper evaluation needs to be done at the time of presentation itself. So here we move on to the next case. Thank you so much, panel, for the first case. So Arun sir, this is a case who is a 9-year-old girl. She has complaints of not growing well for the last 2-3 years. No secondary dentition again at the age of 9 years, which we typically expect to start by 6 years of age. She has dry skin, constipation, otherwise okay, and this is the height and the weight. So again, how would you approach such a child? And I'll quickly give you the growth chart for this.
Yeah. I will go, first I will ask the history of the child, personal growth history, then growth history, then growth history, what is weight, weight, height, and weight of the child. Then I will go ask family history. Then other party I will go to through the investigation like T3, T4, TSS 11 investigation, and if needed other investigation I will send for that. Other like anthropometry, height, weight, and growth chart, and other past history like any disease related chronic disease like adrenal cause. Other I will going to ask with the family.
Yes. Right, so again, a proper history taking is very important because it might give us a clue as to when the disease process started. So how chronic the condition could be. So Jankna ma'am, can you help us interpret this growth chart, what it looks like?
See, from the growth chart, height is more affected and weight is normal or little bit higher sides.
Correct.
So height affected and weight is in a fine condition, so it indicates an endocrine causes.
Right.
And if we have a cross percentiles, if in height, if you have a cross percentiles, multiple height recordings, and percentile crossing is more than 2 lines, then we early detect from the growth chart about
Right.
the endocrine etiology.
Yes. So we always stress that growth chart monitoring is very important, right? Because sometimes just based on the growth chart readings only, we can get a clue of what endocrine or any illness the child could be having. So any short obese kid, you're most likely looking at an endocrine condition. And as ma'am rightly said, there are different growth charts wherein we can see a crossing of a percentile. So any crossing of 2 or more percentiles, something is wrong. A short obese kid, remember we need to do the endocrine workup. So here when the child came to us, it most likely looks like a hypothyroidism to us, and it can present to us with various symptoms and signs, or it can just come to us with not growing well, right? So remember, for diagnosing hypothyroidism, a high degree of suspicion is very, very important. It's a very simple condition to diagnose and treat, but awareness that this condition can exist is very important. So Chetan, we have got a number of tests available, right? And sometimes when we see the files in our clinic, we have a battery of investigations done. So to diagnose hypothyroidism, what do you think, which investigation should we do first?
So just to diagnose the hypothyroidism, we should be looking at very few investigation.
Yes.
First is TSH followed by free T4. I think we know that T4 is produced more from the thyroid gland, but active form is T3. So T3 is least affected, or you can say late affected. So to diagnose just T4, maybe total or free along with the TSH is enough to rule out any possibilities of any either central or primary hypothyroidism.
Correct. So, sometimes we get the sonographies done, some abnormality in the gland and FNS is already done. So just to diagnose hypothyroidism, we just need 2 basic investigations, and that is very, very important. Chetan, if you would like to explain this physiology,
Yes.
The meaning behind getting the test done and what happens in primary hypothyroidism.
Yes. So as we know that T4 and T3 are the major hormones from the thyroid gland, which is controlled by negative feedback from the hypothalamic pituitary region. So in response to the T4 and T3 level, pituitary produces TSH. So if there is defect in the thyroid gland, which is called primary hypothyroidism, your T4, T3 will be low, thereby sending a signal to pituitary and hypothalamus will cause result in high TSH. So any primary hypothyroidism will have low T4 along with high TSH. If your pituitary is at fault, then your TSH will be inappropriately low or normal to the level of T4. So this is called negative feedback, and in a way pituitary controls the thyroid gland.
So all the hormones work on the negative feedback, so it is important to know how to interpret these investigations. Jankna ma'am, are there any conditions, in an asymptomatic child where we like to screen for hypothyroidism, though the child does not come with symptoms of hypothyroidism?
So it's some autoimmune conditions like a type 1 diabetes, celiac disease and autoimmune nephritis, syndromes like Down syndromes and a Turner syndrome, and infiltrative lesions like a hemosiderosis in thalassemia. Any infiltrative lesion that parenchyma will damage, that requires the asymptomatic child to screen for the thyroid.
So especially in our kids of type 1 diabetes, we'll be doing a thyroid function test at baseline and then every yearly. And these are some of the recommendations that annual TSH and FT4 screening are needed. So moving on further, Ruchi, what further investigations are needed, and is there a role of imaging, and what is the first imaging you would like to get?
Right. So if I'm telling this family that your child has hypothyroidism, I need to tell them certain more information. So first I want to know whether, so a bone age would typically help me to find the origin, like when should it must have started, so as to understand the growth potential and sort of the origin of the condition, the age. So that would probably be the first and very most important radiological investigation that I would like to do. Another things that we can do is thyroid antibodies to see if they are positive and to label it as autoimmune thyroid disease causing hypothyroidism, to sort of counsel my family that this is a permanent condition. It may not be required always, because sometimes diagnosis is very clear cut, but these positive antibodies will help you counsel the family of the permanency of the condition. Alongside a ultrasound, which can also suggest the changes of thyroiditis, again that is also sort of helping me to
convince the family.
Yeah, because basic palpation of thyroid gland is quite important and it can tell us a lot of information. But an ultrasound report will help convince the family also that this is going to be permanent and your child will need thyroxine for life.
Yes. So Dr. Chetan, how do we treat this child?
So by looking to the reports as well as bone age and symptoms, it looks like it's a long-standing primary acquired autoimmune type of hypothyroidism. So definitely the body is accustomed to the low thyroid status, and as we know that thyroxine is a catabolic hormone, we would like to start gradual dose,
Yes.
and then over the next 2 to 3 weeks of treatment, we should be reaching to up to the normal required dose. As the age progresses, the requirement of thyroid gland is decreased. So according to the age, we should be treating the acquired hypothyroidism. Again, I would say for first 2 to 3 weeks, treat with the half dose and then gradually increase the dose to the full strength.
Yes.
And
So I
TSH,
think that is a very, very important point, right? Sometimes what we do is we directly begin with the higher or the recommended dose. But remember, in our kids who come to us this late with a delayed bone age, remember it's a chronic condition. So begin slowly and then gradually build up the dose. Yes.
yes. And while treating, we know that the TSH is a long-standing, TSH has been high in long-standing, so definitely we should do TSH after 6 to 8 weeks to monitor the therapy. Otherwise, many times our pediatrician's friend does the TSH, they do after 1 week or 2 weeks, and TSH is still high and they tend to increase the dose. But no, TSH will take time to recover and coming back to the normal. So repeat TSH should always be done after 8 to 10 weeks of the therapy.
Yes, TSH is a parameter which will take some time to get down. So if you just keep on repeating the TSH, you might overdose this child. Very, very important that thyroxine be taken in the morning on empty stomach, and any food or drink be given at least 30 minutes after the medication only. Right? Arun Kumar sir, how would we monitor these children? Because treating is very simple. You just have to give a small tablet in the morning. But the most important thing to do in hypothyroidism is to monitor these children. So how would we do that?
We started the medicine, and every 3 to 4 months we will give lab investigation T4 TSH, and after that in case dose changes or in a case of repeated then thyroid function test, we will perform for 4 to 6 weeks.
Yes.
And if the complaint of other symptom or anything, we will investigate, or we will send for investigation, and growth parameter like height, weight, every visit we will measure in the height chart, and even prescription book, and other like staging, we will do a staging, Turner staging for developmental of
Yes.
child.
So as you said, monitoring is a very important aspect of any kid who goes on thyroxine. So let me just quickly summarize that this is the most common hormonal disorder in children. Remember, simple FT4 TSH is the investigation of choice. Antithyroid antibodies may be done to establish the autoimmune nature. Bone age is necessary. A sonography and a thyroid scan are not needed or not mandatory to start treatment. At the first visit itself, please convey to the family that treatment is going to be lifelong. Age-appropriate dosing of thyroxine has to be done. Regular monitoring in terms of using growth charts, getting your blood work done at regular intervals, monitor for puberty. That is all very important. So we move on to the next case, which may be not in the typical adolescent age, but very much relevant there. We've got a 7.5-year-old girl who has got complaints of pain in the breast area. Mother reports that she has been growing very fast in the last 6 months. She's otherwise well, milestones are normal. So when we asked the family history, mom said she had her periods at 13 years and dad started shaving in first year of college, and she's otherwise well. So Jankhana ma'am, we have got a 7.5-year-old kid. How do we approach this child, and what information do we need next?
This is a 7.5 years old child with growing fast according to the mother and a breast pain. So first I would like to have anthropometry and a growing fast. So I also want to know the mid-parental height also, to what is the target height, and SMR staging, about an SMR staging. So this is examination wise, this is a B3, A2 and a P1. So breast is fully developed, and systemic examination to rule out any systemic diseases.
Correct. So here what we see that this is the target height, but the child seems to be growing at this point of time taller than the target height. Yes. So remember, if a fast growing child comes to us, remember excess hormones, either sex steroids or thyroxine. So that needs to be ruled out. So just based on the clinical information, Arun sir, can this child be caused as having precocious puberty? Like, what is the definition of precocious puberty?
If the child girls before the age of 8 years, or why age of 9 years is considered as a precocious puberty. And this case, I think child is due to we have to rule out other cause in this child.
Yes.
Thank you.
So any girl who has a Tanner stage breast 2 below the age of 8 years, pubic hair stage 2 below the age of years, or has periods before the age of 9 years, and remember for boys it is going to be measurement of the testicular volume. So any testicular volume more than 4 ml in a boy less than the age of 9 years, here we are looking at a case of precocious puberty. It remains to determine whether it is central or peripheral, but this is a case of. So if we just quickly summarize, we know that she is 7 years, 9 months, breast enlargement has started, there is increased height velocity, so clinically, this child definitely has precocious puberty. So moving on, Dr. Ruchi, how do we proceed further and which investigations do we do next?
Yeah, so this has sort of become such quite a common scenario these days, that girls are presenting with early maturity, early puberty, and we are receiving lot of children with this. Child is already breast stage 3, so it is like it's possible child's been in puberty for last 6 months or so. I would want to know whether this early maturity or early puberty is going to cause two problems. One is whether the child is going to get mature early and have menarche early at a very early age, sort of immature to handle that, the whole course of puberty and menarche, socially, emotionally, every way, and whether the height, the final height would be affected, because typically with menarche the height velocity starts decreasing and the epiphysis start getting fused. So first important thing would be a bone age to see how much height potential for the child is left. Already at such young age, her bone age is already advanced by 2.5. So whatever estrogen has been present for last couple of months has already advanced her bones by 2.5 years and has reduced her height potential, because the bone age is on 10th percentile. Likely the child's predicted adult height is much lesser than what it looks like right now. Child must be quite tall in the class, maybe tallest in the class, but it is possible that she'll stop growing early and will eventually remain short. So bone age would help us even counseling the family regarding whether we want to intervene in this thing or not. I would also want to know the etiology of precocious puberty. I would want to rule out any pathological causes. Sex steroids, early morning LH, FSH, estradiol will tell me the sort of the amount, whatever is going on biochemically in the body. We may or may not be able to find LH, FSH, but clinically, since the child is pubertal, they are likely there, estrogen is around. Thyroid function test, because severe hypothyroidism with very severely elevated TSH can mimic FSH function and can cause breast development and even sometimes vaginal bleeding. So, and then ultrasound will tell me the effect of estrogen on the uterus and the ovaries. So if I want to rule out any ovarian cysts or any follicles which may be causing excess estrogen autonomously, and also the effect of the estrogen on the uterus and ovaries and endometrium, that to predict sort of progression and also predict little bit of menarche.
Yes, so I think these are the basic investigations that we need to get it done: a bone age, a UST pelvis, thyroid hormones, and LH, FSH, testosterone or estrogen. So this is what came back. LH is 1, FSH is 3.2, and estradiol is 25. So based on this blood work, Dr. Chetan, can we say it is central or peripheral? How do we differentiate? Should I go to the next slide?
Yes. As we discussed earlier, LH more than or equal to 0.3 is suggestive of onset of puberty. So definitely LH is pubertal, you can say, as well as estradiol more than 10 is also suggestive of onset of puberty. So in this case, we can say that puberty has been started from hypothalamic pituitary region. So this is a case of central precocious puberty. Because we know that GnRH from hypothalamus stimulates pituitary to secrete LH and FSH, which acts on the gonads, causing production of the sex steroid, which ultimately leads the puberty. So in this way, central precocious puberty starts from hypothalamic pituitary region and then comes to the gonads. So this is a case of central precocious puberty, while peripheral precocious puberty, the fault is at gonadal level or maybe extra pituitary level, in which LH, FSH are suppressed and only sex steroid in form of estrogen and progesterone are high. Majority of them are produced from the gonads without the effect of GnRH and LH, FSH.
Yes. So CH is a very good example of a peripheral precocious puberty, wherein the adrenals make too much hormones, but when you get the blood work done, your LH, FSH are going to be suppressed, right? So Ruchi ma'am, how do we manage this child? And quickly, if you can just say what could be the consequences if we don't treat a kid with
Yeah, so
precocious
I think
puberty?
some of it we already discussed, that untreated precocious puberty. So the child will progress in puberty and eventually, so in girls, typically the duration of puberty is around 1.5 to 2 years. So starting from breast enlargement, breast stage 2 till menarche is around 1.5 to 2 years. Sometimes even overweight girls might have early menarche in the course of puberty as well. So
We have
one
been
is that-
granted more time, so please ignore the alarm.
okay. So we are seeing children at 9 and 10 years who are looking like adults, and so when their physical appearance is different, even the expectations and societal expectation, everything differs. So that is, early maturity is one problem. Menarche, again, handling periods is another problem. Fusion of epiphysis and short height, eventual short adult height is another issue. So untreated precocious puberty can lead to a short adult child.
So Chetan, can you say what is in your practice? How do you manage, how do you treat these kids with central precocious puberty?
Yes. So central precocious puberty, we need to suppress the gonadotropins and LHFSH. So we are using GnRH analog, which continuously stimulates the pituitary, and hence LHFSH will be suppressed. So they will be suppressing the ongoing puberty, as well as they will delay the bone age maturation. So GnRH analogs, preferably over 12 weeks, is the standard mode of therapy till the girl reaches minimum of 10 years of age, and we can even prolong the therapy beyond the 10 years of age as well.
Yes. And it is a very safe and effective
Yes.
way of treating precocious puberty. So any girl presenting to us should be offered this treatment. Like, it doesn't have any long-term effects on fertility or infertility, because that is the biggest concern. So we now move on to a very important and a close topic to our hearts, because as adolescent creeps in, lot of things happen to our type 1 kids. So Jankna ma'am, I would like to know, does the management differ in an adolescent who has been diagnosed with type 1 diabetes, or does it remain the same for any?
So many things are same in form of the monitoring, insulin therapy, nutritional therapy, physical activity. One thing is different is adolescence requires little bit higher dose of insulin than others.
Yes. So practically our management principles do not change. We have to give insulin, we have to thoroughly monitor, we have to do our medical nutrition therapy and lots of physical activity. But adolescence is a time where there are so many hormonal changes that might cause increase in the insulin requirement. So often you end up giving sometimes even to the rate of 2 units per kg per day amounts of insulin. The child is going through growth spurt. This is the time when kids actually realize the permanence of type 1 diabetes, and therefore all the psychological issues, the acceptance, the commitment towards care start coming into picture. So we are just quickly going through a couple of case scenarios. Arun sir, this is for you. This is an 11-year-old boy, has type 1 diabetes for the last 2 years. The child is on a basal bolus therapy of Glargine and Lispro. On routine follow-up, the HbA1c is 8.4. And this is what the logbook looks like, right? So if you can quickly see, most of the sugars are normal, but the morning sugars are on the higher side. So Arun sir, if a logbook like this comes to our hands, how do we manage the high blood glucose in the morning?
Thank you, ma'am. Mostly sugar level at the morning is 232 and 202 and 254 or even more. But as compared to lunchtime and even evening is normal. So I like to do monitor at 3 a.m.
Correct.
and I will see Somaji effect or down phenomena. If insulin level is decreased, then I would like to add with there is retained milk, and I will add some chapati or carbohydrate and protein food if needed. Then otherwise, if normal, then also again I review the insulin, and I advise to for physical activities and other stick about nutritional advice. I will give.
Yes. So whenever we see such high before breakfast sugar, now remember it's a very common phenomenon. All the hormonal surges are happening at 4 to 6 a.m. that cause the high before breakfast in the morning. So as sir said, we have to check our 3 a.m. sugars to know whether it is going for a dawn phenomenon or a somogai phenomenon. Dawn phenomenon meaning throughout the night the sugars keep on increasing. So either we give some physical activity at bedtime or we increase the dose of our bedtime glargine so that the morning sugars come back to normal. But if your 3 a.m. sugars are dropping, which can sometimes happen, and that is what is known as the somogai phenomenon, in that case either we offer them a bedtime snack so that there is no hypoglycemia at 3 a.m., there is no surge in the morning, or we increase the dose of our bedtime glargine to take care of the counter-regulatory hormones in the morning. Another case scenario, I've got a 14-year-old girl, she has type 1 diabetes for the last 6 years. She's on follow-up, she came to us after a year. She is in 9th standard looking very confident. HbA1c is very high. But Chetan, this is the logbook. No, HbA1c is 11.5, but I think the logbook shows all good sugars. So what do you think is happening here?
So many of our patients are coming like this, where there is a discrepancy between glucose logs and HbA1c. So most common thing, just we ask to the parents that whether child is recording himself, that many a times it happens that child, though glucometer is showing high reading, child writes down as normal readings.
Yes.
So that he or she can be saved from the scolding by parents or even advised by the doctor, number one. Number two, glucometer might be defective as well. So first we need to focus on these technical areas rather than going to find another causes.
Yes.
70-80% patients are like this only, that because
so they are very
HbA1c.
smart people.
Yes.
They know how to fool us. So let us not be fooled, right?
Yes, right,
yes.
right.
Yeah. So I think thank you very much for the panel discussion here, and we hope you had a great time. Thank you very much.
Thank you, madam. Last but not the least session, and thank you all panelists. Any questions?
I have one quick question. What is the reason for this early puberty nowadays? What are the reasons
Ruchi,
nowadays in children?
if you can tell us, that is also good. Chetan, you want to please answer?
No, we don't really know for a pinpoint cause. Whatever changes have happened over last 5 to 10 years, especially post-COVID, relatively sort of healthier pre-pubertal age, meaning girls being more overweight and obese, but somehow this trend of overweight and obesity is also seen in boys, but we are not seeing early puberty in boys. Boys are still following their fathers or uncles. So yeah, but this trend has been uniform all around the world. There are papers from all around the world showing that girls are going into puberty early. Lot of things have been linked, like even there was a paper that they said that sanitizer used during COVID led to early puberty, or the screens have effects on the hypothalamo-pituitary area, but we do not have a exact reason why it happens. Sometimes even you find a girl 7.5 and everything has been fine, like you don't find any like child is lean and thin, there is no excess screen time, nothing, and still child is in early puberty. So we don't really know, but this trend is...
So I think the most important thing would be for us as pediatricians to be aware that precocious puberty is very common,
yeah,
and that
looking at
treatment can be
secondary
offered
sexual
to them.
characters, like look for pubertal features in a child who is coming to you after 8 years. That is the main
Even after the age
message.
of 6, I would say, like SMR staging is recommended for any girl after the age of 6 now.
Even you can just ask the mother, if at all you don't want to examine, and if you are a male pediatrician, then if there is any breast development which is going on, then mother might tell, ha, એવું લાગે છે. So I think then we should examine thoroughly. Yes.
Yes.
And madam, what about the trend of now we are seeing really obese kids? So, I mean, it's obesity we are seeing in boys and girls both. And like now when we see a 10th standard or 12th standard boy, they look really like pubert. They look really more than their age.
So one thing is that those children who are overweight or obese before the start of puberty, they are likely to gain more weight during puberty. That is one thing. Obesity, the reasons we know, like we've discussed all, whatever changes in the lifestyle which we are seeing, that, yeah, but girls, so typically, technically speaking, we say that adipose tissue...
Can I just add? So lot of now we are seeing IUGR, low birth weight babies, SGA babies. Remember, overfeeding of them to normalize their weights have to be avoided, because 4 to 6 years is a time where they'll have a rebound weight gain, right? So let us make sure that, especially that, because that is a big group that is increasing now, they have a high risk of developing metabolic disease in the future and going into obesity naturally also. So again, that is one
Yeah, so and the,
chunk where-
something like technically speaking, there is a increased aromatase activity in the adipose tissue. So that is also likely that, you know, even the girls who are overweight and obese, they are likely to progress faster in puberty.
There would be a role of formulas as well.
Yes.
So the onset might be right from birth.
Yes. Yes. So again, the importance of breastfeeding. So thank you so much. Thank you, panel.